So identifying the character Toby as a potential depiction of histrionic personality. How long, um, either into the episode or into getting to know her, did you feel that she may be afflicted?
From when she first opened her mouth, I was like, the word histrionic came in, but as like the word that you learn before you go to medical school, before you learn it's like a personality disorder, just like that word as an adjective
Right.
without the PD next to it. Yeah.
Good point. Good point. So, um, histrionic personality disorder requires, I believe, 5 diagnostic criteria. I'm guessing, because most personality disorders require 5. There is no chance that she demonstrated 5 or more traits. On the other hand, you begin to feel that this is something that you might be able to clinically suspect and therefore investigate if this were an office setting. Why? How does that happen? Not for this particular clinician or this particular patient, but explain to me how things like this come to mind when clearly content-wise, the patient, we'll call her Toby, um, is only in front of you for moments, yet you're thinking this might be histrionic personality. What's going on there? Can't call it intuition. You're too young. It's called countertransference. Right? Countertransference is or are the feelings that people in general, certainly patients, ignite in you. Right. One of the things that readily separates psychiatric training from any other training is the 1 year of psychotherapy during their PGY3, where they learn the feelings that patients make us feel has nothing to do with us. And has everything to do with the interaction and therefore them. And when you begin to understand that, when you can acknowledge that, even when those emotions are bad, God bless you, see, it's true. The next step then would be for you to begin to understand why. Why are they making me feel like this? Why is Toby making me feel like this? And after a session where you begin to look for content and begin to ask focused questions, in this case, for example, you might actually find 5 characteristics that rise to the level, the threshold of histrionic personality disorder. So it's not content. She didn't rattle off 5 diagnostic criteria in 5 minutes. It's process. And the specific process is called countertransference. Our psychiatry residents unlearn all of the good habits our parents teach us. You shouldn't feel that way towards people. Right? That's bad. Right? Mom and dad don't want you to feel like that, think like that. You have to, especially in therapy. Because if you miss those emotions, you may miss something big. Not necessarily a diagnosis, although that could be missed too. Even things more important than diagnoses, and that is some of the things that are going on conflictually in the person sitting across your desk when you dismiss your own feelings, as negative as they might feel. Right? And you nail it. I mean, I think she does have histrionic personality, despite the fact that she really doesn't give us full criteria. Right? And it all kind of stems from countertransference. Any other observations about Toby? Did you like her? I got to know.
I think it was interesting how.
Would your parents be proud now? This is a great example of how we have to undo that. Right? Now, don't go back and tell your mom and dad we're doing this.
Oh yeah, with Toby, I think it's interesting how like at the comedy show she can heckle and do all that, and it's kind of acceptable, but also a little bit annoying. But it's at a comedy show. But then when it happens to her at the office, that's considered totally inappropriate. It's like just the idea that in certain social settings things are accepted and in others it's totally not.
Almost definitely. Oh yeah. Yep. Yep. So social settings build an unwritten curriculum. There's no way a medical student has ever entered my office and thought to sit in my chair. Right? Yet when you enter a room, that necessarily just because of the type of furniture, where it is, and then who's in that space, can absolutely have you sit in that chair. Social situations build an unspoken curriculum, a hidden curriculum, and that's a hierarchy that is embedded and not necessarily conscious. Right? That's what's going on here too. Yep. But you avoided the question. Who else wants to render, did you like Toby? I got another no. It's difficult to admit that you don't like some people. But again, that's countertransference. If you dismiss that feeling, and I don't know if this episode really kind of bears it out, but you could miss something clinically significant, right? And I would equate this to your not liking or your being rubbed the wrong way by somebody who appears combative, to find out that the glucose is 20. If you ignored their combativeness and said, my mom and dad taught me not to judge people, you might miss that life or death situation. And that's a little over the top in an example, but you get my point. All right. It is not okay to dislike someone and then, call the cops on them or, get somebody to follow them or fire them. But acknowledgement is just a sign that you've got to help them and where that help is needed, probably.
I just have a quick question. So, like, on this principle of countertransference, where you like actually acknowledge your feelings, I was wondering how you think that interplays with that whole concept of, a bias in the healthcare system, where we know if we treat people that don't look or experience the world like us, they may receive different or reduced health outcomes. So, if I'm actively like acknowledging those feelings, which may be rooted in a lot of like societal determinants, how do I also like reconcile that to make sure I'm not providing inferior care to my patients?
Yeah, so I think there's an academic answer, which I'm going to obviously give you right now, but there's also a practical one too, which I'm not so sure is realistic, and I'd actually like to hear your feedback on that. Pedagogic answer is that it's that second step, acknowledgement of a negative emotion by a clinician from a patient, from a consumer, is the first step in a process. To actually acknowledge, this person frightens me, I'm afraid of them, is a breakthrough. It's a necessary first step. It's foundational. But if that's all you do, you haven't done anything for your patient. The next step is some introspection. Why? Why is it that they're making me feel like this? And the answer is going to be A, B, or C, right? It's going to be in part or due to my feelings and what baggage I'm bringing to the table, what baggage they're bringing to the table, and a combination of A and B, right? And then C, in that final step of the process, is how do I reconcile this for the betterment of my patient? I think the easy example here is the individual who notes, I don't like this person because their belief system is divergent from mine. That's the necessary first step. But if you don't do anything with that, you could easily take a negative direction. So it actually becomes counterproductive, right? The very thing that results in a potential breakthrough in psychiatry is misused, and it goes in the direct opposite direction, and that can't happen, right? So that's the teaching answer. The practical one is, well, okay, how do we? The third year in psychiatry training is wonderful because this is where our psychiatry residents learn this stuff for a year. But psychiatrists only make a small percentage, or make up a small percentage of the physicians in the U.S. So it's wonderful that psychiatrists get this, and not all of them do, but for the most part, our residents do. We get it, right? The practical answer is every discipline that interacts with patients should have X number of months, probably in their late year, their third year, maybe even some residencies their fourth year, to rotate through psychiatry to learn this stuff practically, so they can bring it into their future non-psychiatric career and vocation. That's the practical aspect, which I don't think is feasible. I don't see that happening. Matter of fact, the direct opposite is happening. The board for family medicine, the board for internal medicine used to require residents rotate through psychiatry for 1 month. But it wasn't for psychotherapy and learning this practical stuff. It was just seeing some psych illness. They've done away with that. Internal medicine now has pulled their residents from our service, and so has family practice or family medicine. Family medicine now, I think they continue to shadow psychologists in the community. And so I don't know what internal medicine does, but I knew that there was a transition where 1 day a week they would be with us. X number of days a week they'd be pinched to cover other services, and 1 day a week they would do emergency room. And then the 1 day a week they were with us vanished. So they don't even get that anymore. So I'm not sure how practical it is. Back to Seinfeld, back to funnier stuff or funner stuff. What other characters you want to discuss this morning?
For George, after the fire, and pushes everyone out of the way. He really rationalizes why he does that as a defense mechanism.
And again, George acts on an impulse, fight or flight. His superego did not kick in, otherwise it would have been, again, older vocabulary, women and children first. But he certainly doesn't follow that rule. His superego does not kick in. It's somewhere on vacation. It's simple hypothalamic fight or flight, and he fled. No doubt about that. Now, after whether the fire was real or not, afterwards, there's going to be the reality principle that kicks in. Why did you act like that? That's the superego now, and the superego certainly paired with others' objective opinions. What was that about?
Like, I mean, I think on that point, I think Robin's response is interesting because essentially she's categorizing, like she's making a decision on the way he interacts with the world based off like whether he prioritizes the superego versus it, essentially, and whether and how that she wants to be associated with that. It's interesting.
And maybe there's multiple people have opinions on that, and even viewers. But the fact remains, he acted on as an impulse, fight or flight. It was survival for him, even if it came at the expense of others, including children. When the superego, by acting in accordance with the reality principle, conflicts with the id impulse, that causes or induces anxiety. That's what Freud, that conflict is what Freud termed anxiety. And rationalization is a product of the ego, an ego defense mechanism that dissipates anxiety caused by the conflict between the id and the superego. You see that all play out in that scene, and rationalization probably is the single best answer of what defense mechanism is employed following that scene. Quick clinical pearl on defense mechanisms. I think when Valiant first kind of categorized narcissistic versus immature versus mature, they showed up in shelf exams. Not that there were really shelf exams back then, but they showed up in shelf exams. I think clinically, and they may or may not, but clinically, it has less to do with the initial categorization. Borderline personality disorder, splitting immature, that is true, but probably not as important as one's flexibility, being able to utilize one defense along with another in exchange for yet another. That flexibility is what builds ego strength and is a protective factor against mental illness. On the other hand, rigidity has the direct opposite effects. You could take the most mature defense like humor, and it could become very maladaptive and causal when it comes to a mental disorder. Valiant says, well, sublimation, humor, these are mature defenses. But if they're inflexible, they could cause as much damage as any of the narcissistic defenses that are flexible. So it's more of a clinical pearl. And it's, again, something we investigate in psychotherapy, especially if you employ psychodynamic psychotherapy where you believe in this stuff. Any other thoughts about George? Any other characters you want to discuss this morning? Yeah. Anybody pick up on why this episode was assigned today? No?
Because of what we just talked about, like the ego defense and the fire.
No. Well, the fire, yes. It has something to do with the fire. It also has something to do with another issue or topic you brought up, the two of them, the fire as well as one of the characters. Who else did we talk about this morning? Yeah. Have you ever seen another non-Seinfeld episode that has a fire in Toby?
The Office.
They're
Is that what
fun.
you meant? The character name?
It could be. Was there a fire in one of the episodes?
There was a fire.
Good for you.
episode.
If we were doing it, yeah, if we were doing office stuff, an episode. That's exactly right. But that is not the reason, though. But it's correct nonetheless.
Okay, well,
It's not your bad.
Nice.
Actually, it's actually a correct answer. It's just that we don't use the office to teach, which is that's our bad, not yours. That's paranormal activity.
Oh.
Yeah. So for those of you who know the franchise, you know that Toby is one of that's Hunter. Toby's the demon that's going to get Hunter.
That's right.
Yeah. And there's a fire that plays a major role in this franchise. If you've seen any of the sequels. All right. Well, that's just a fun fact in terms of living in October with this rotation. Final thoughts? Seinfeld, the fire.
The part where the boy is like under the table and like being really disruptive while they're trying to have brunch, like that reminded me of like a year-old question where they tell you about a child being like disruptive and they're like, normal behavior for ADHD.
Yeah.
And it's like you can't really tell because there's not more than one setting in this case. I guess it's just like a little snapshot, but it just made me think of that.
Exactly right. Yeah, and I hope that normal behavior is always choice A because it would be consistent with the way your brains need to be trained to think. Irrespective of why the individual, child, parent, both, other, made the office appointment, and no matter what they tell you in terms of their chief complaint, their chief concern, it's always normal until proven otherwise. In this case, they would need to prove to me that this type of disruptive behavior is not only clinically significant but crosses social situations to begin to think of a mental disorder and perhaps in that case starting with ADHD. Right. Yep. All right, we'll leave it there. Basically, that's as much child psychiatry as I can actually muster for a week, a month even. We'll leave it there.